So is somebody going to introduce and then I'll start?
Yes, sir.
Yeah,
We'll be doing
Vanita
that.
will introduce, yes.
Sounds good. Okay.
VLI.
Good evening, everyone. Welcome to iFocus Online, Lecture 147, Glaucoma Session 51. And we are here with our International Masterclass. And today we have with us Professor David Friedman. And I request Dr. Vanita ma'am to please welcome him. And good morning to you, sir.
Thank you.
Yes, indeed, Professor David Friedman. Very good morning to you. And it is indeed a great pleasure and good fortune that Team Center for Sight has managed to get you in for a very relevant lecture of current concepts in angle closure glaucoma. And because notwithstanding your stellar work in this field, and of course, it gives me great pleasure to introduce you to our ophthalmologists in training, although worldwide, you're very well recognized. We're all very, very aware. So Professor David Friedman is the Albert and Diane Kaner Chair of Ophthalmology and Director of Glaucoma Service at the Mass Eye and Ear in
Boston.
Sorry. Very sorry about that. He did his ophthalmology at the Johns Hopkins University and his residency at Wells Eye Hospital, fellowship at Johns Hopkins yet again, and a PhD and MPH as well from Johns Hopkins. He's considered a leader in all three fields of any specialty: clinical care, research, as well as education. And he has been consistently elected as best doctor for last so many years. He has lectured not only domestically in the US, but internationally as well on glaucoma care. He's known for his contributions, as I was saying, on the study of the mechanisms, epidemiology, and prevention of angle closure glaucoma. And in this regard, he has worked very closely with researchers in China, India, especially with Shankar Netralaya and Arvind, as he was just telling us, Thailand and Bangladesh. He's been one of the major contributors in the Eagle trial, which we're all aware of, as well as the Zhongshan angle closure prevention study, both of which were, of course, published in the Lancet. He's also contributed several research in the area of medication adherence, another very important issue. He has received various awards, co-edited a definitive book on angle closure glaucoma, and has published nearly 300 peer-reviewed articles. He has featured as top 100 ophthalmologist in The Ophthalmologist from what I saw 2020, 2018, 2019 and 2018 as well, if I'm not wrong. And not only does he see patients from around the world for challenging surgeries, but he is a member of the Glaucoma Research Society, which we all are aware that is limited to 100 leading researchers globally, as well as the Alcon Research Institute, which is really composed only of the top 6 researchers in ophthalmology each year. So we extend a very warm welcome to Professor David Friedman and invite him to deliver his lecture today on current concepts in angle closure glaucoma.
Thank you very much for that very kind introduction. So let me pull up the talk. I'm sorry, and we'll get started. And we'll have a time for some question and answer at the end. This is intended to go for a little less than 40 minutes. I have no disclosures. I'm sorry, can you hear me?
Yes, sir. You're
Yeah.
perfectly
Okay.
audible.
I have no disclosures relevant to this talk. I think that you're well aware in India how prevalent angle closure glaucoma is. It's really not as prevalent as open angle glaucoma, as shown here in these estimates, but it is as responsible for blindness as open angle glaucoma. And that's because angle closure glaucoma is more frequently severe, and I'll show that in a moment. If you look by region, the prevalence estimates vary, but in Asia, it's about 1%. In North America, Latin America, Europe, it's probably about 0.5%. This translates into very large numbers in the Asia region because it's more prevalent and the populations are large. So there's just an enormous disease burden in your area of the world. And as I was saying, angle closure is more frequently blinding than open angle glaucoma. These are well-designed, population-based clinical studies looking at the rates of glaucoma and the outcomes of glaucoma after going door to door and identifying individuals and examining them. And the range, is very variable, but quite high for monocular blindness in angle closure glaucoma and much lower in open angle glaucoma. And I think this does bear out clinically as well. Just to summarize, if you look at Chinese or Indian populations, estimates come in at about 1%. There's this really unusual population in Myanmar, at least in one large, very good population-based study, extremely high rates of angle closure, and the rest are about 0.5%. We use UBM, ultrasound biomicroscopy, to get very detailed angle images. It gives good visualization of the ciliary body, the angle, and you can see the S is the scleral spur, so you can determine if the angle is open or not using this. And this is very helpful for understanding mechanisms of angle closure. And I'm just going to go through some of those. If you look on your left, you see an open angle. And on your right, that's more or less a closed angle. Gonioscopically, that small slit would appear closed. And one thing that you can see is there's a fairly high iris insertion. The iris is fairly bowed. All of these images I'm going to show you are in the dark. In this image, the thickness of the iris in the periphery on the right, the way it rolls up and clogs the angle, is a major contributing factor to angle closure. If you look on your left, that iris is inserting very close to the scleral spur location. And so it would be very easy for that angle to become closed, a little pupil block, a little bit of ciliary body rotation, any of those could push that angle closed. Whereas the one on the right really would be extremely hard to identify as a closure eye, no matter what you had. You could have a tremendous amount of ciliary block, you could have pretty shallow anterior chamber. None of that's going to affect or make this a closed angle. And even on the left, I mean, you could see it would be impossible ever to close that angle given the distal insertion. As I was noting before, there are certain configurations we tend to see in angle closure. On the right, you're seeing typical pupil block with a bowing of the iris. On the left, it's much more of a plateau configuration, also referred to as a lobster claw kind of configuration by Bob Rich. But you can see that these different ways of presenting would probably respond differently to iridotomy. And so someone on the left would be far less likely to open up because they don't really have much of a pupillary block component to their angle closure. What I'm trying to demonstrate here is that there are multiple components to angle closure, and any eye's individual cause of angle closure is a combination of those factors. This is once again another example of the iris roll. These things were described back in the 1950s by very good people performing gonioscopy. And it certainly is true that an iris that rolls up like that on dilation will be more likely to close in dilation. And here's more examples of the plateau configuration. I would imagine that the iris on the right, no matter what, that angle would stay closed after an iridotomy. You can see that the ciliary body is really pushing this up into the angle and holding it there. And it's not really a bowing or a pupil block configuration. When we talk about angle closure, and I'm going to talk about the range of angle closure today, we want to make sure that the terminology is consistent. And when I first started doing research in this area almost 25 years ago, there was a very wide range, and there are important clinical terms. This terminology does not account for people who have intermittent attacks, for example, but I think this terminology does help to clarify which populations are being studied. So we have primary angle closure suspects, and these are people who were normal until you did gonioscopy. They have no evidence of disease, no visible posterior trabecular meshwork for about 180 degrees, but their pressures are normal and there's no disc or field damage. So basically, this is somebody you look in, and unlike the person on the left, where you see the structures and you're able to say that that's an open angle, it's more like the person on the right, where you just can't see the structures in primary position. And I say in primary position because that's how we do it. You could push and maybe open it up, but we're talking about people who have no visible TM when you're looking in at the angle. There's a second condition, which is not a disease, but it's something that gives you a little bit of pause that maybe it could result in disease, and that's primary angle closure. And in this case, you have the same iridotrabecular contact, but there's some evidence that something more is happening to the eye. There's still no disc or field damage. And the two things that we consider worrisome are peripheral anterior synechia or an elevated eye pressure. And the reason that we include eye pressure in this definition is we don't think it's by chance. So typically I'll argue you really don't want eye pressure in your definitions related to glaucoma, but here it may be telling you something. And the reason we think that is you would be very unlikely to see a high eye pressure with angle closure just by chance. And the reason I say that is if you picked, let's say, older Indian women, and they had a really high rate, let's say a 20% rate of angle closure, which would be quite high, and you picked an eye pressure range in the 5% chance, then the chance of both of these occurring is the multiple of those probabilities, or 0.2 times 0.5, which is 1%. So when we see elevated pressure in the face of an angle that's closed, we believe that this is due to the closure and there's some damage or injury going on in the trabecular meshwork, and that's why the pressure is going up. Obviously, 1 out of 100 times, this could be pure chance, but most of the time, it's something more. What about glaucoma? We reserve the term glaucoma for eyes that have disc and field damage, not eyes that have angle closure. So you refer to people as angle closure glaucomas only when they have angle closure and optic nerve or visual field loss. And then there's this other thing, which is an acute angle closure crisis. So I was a resident training and I got called down for an acute glaucoma. There's an acute glaucoma and I saw the patient, they had angle closure. We treated them and they never developed glaucoma and they did just fine, which is true for about 50% of acute attack eyes. And so now the question is, why did we call that acute glaucoma? And my argument, my belief is we should not call that acute glaucoma. This is a condition where someone could develop glaucoma, they could develop loss of vision, but they may not. And so that's why we gave it the terminology crisis like that. We've found out from a lot of our work that angle closure is highly driven by the lens. There's a lot of risk factors, like I said, the iris thickness, the insertion. I've given you all of those in the UVMs, but the lens has come to play a special role in our thinking about this. And this just shows an anterior segment OCT, which can give us the full anterior chamber, which was a really big breakthrough when this first became available about 20 years ago. And you can see we can draw a line from scleral spur to scleral spur and see how far the lens is projecting into the anterior chamber. And it turns out that that lens vault is a strong predictor of angle closure. And that makes sense because if the lens is more forward, you're more likely to have pupil block and you're also more crowded in that space. And we have a pretty good literature showing that when you take out the lens, it alters the structure of the angle. So if you remove this lens pre and post, you can see the angles are much wider open. And here's another example like that where we did the iridotomy and the angle stayed mostly closed on the left, but after lens extraction, the angle was much more open. And this just shows using shine fluke photography, the same thing, that in both open angles shown on the right and angle closure shown on the left, the angle widens dramatically. And this may in part explain why lens surgery, cataract surgery, lowers pressure in open angles as well as angle closure. And this was a very interesting paper on people with plateau, showing that even with plateau, you open up the angle after cataract surgery. I think one of the really important paradigm shifts in treatment of glaucoma in the last decade or two is the treatment of acute angle closure attacks. There's been a well-known phenomenon that the fellow eye in acute angle closure has a pretty high risk of developing an acute attack. About 10% of those with angle closure presenting in one eye actually have it present in both eyes. And I remember as a resident, we had a patient come in with bilateral acute angle closure, and everybody was like, what's going on? Is this uveal effusion syndrome? Is this drug-induced? What's going on? And then if you look from a island-wide registry in the island of Singapore, 10% of patients present that way. It's just we don't see that many acute cases any given year as an individual physician. And so we are unaware that this is not that uncommon a phenomenon. What's really important to remember is that the fellow eye, the contralateral eye, has an incredibly high risk of an acute attack. It's 50% or so. And the way we know that is prior to having laser treatment for the fellow eye to perform an iridotomy, there was only surgical iridectomy. And many patients who had severe loss from their acute attacks were reluctant to have a surgical procedure in their only seeing eye. And that led them to postpone or not even have surgery to do the iridectomy. Ultimately, half of those people developed acute attacks. That's very worrisome because, after an acute attack, you can have severe loss. About 10% of people are blinded by an acute attack in the eye. So we have to be worried about the fellow eye, and you can have contralateral involvement within days in the fellow eye. In my practice, if somebody comes in with an acute attack, I try to do the iridotomy in the fellow eye that day. I don't want to send them home and plan to do the iridotomy because there is a small chance they could go home and have an acute attack. There have been publications of multiple ways to break acute attacks. You can do a laser gonioplasty. So if medicines are not working, you can use the laser to laser the peripheral iris, and it will open up the angle quite rapidly. You can do a paracentesis. I remember when I first heard about this, I thought this was kind of insane. I still worry a little about it because it is a rapid decompression of the eye, and I worry that you could cause harm, but I have done this and I think it's perfectly reasonable. You can take a 30 gauge needle, and if you tunnel through the cornea a bit and then enter, you'll have a self-sealing wound, which will break the attack quite rapidly. And then there's cataract surgery for acute attacks. This was one of the first real publications on this topic. And these were patients who had a mean pressure prior to cataract surgery, and they were randomized to either an iridectomy, this was Germany, and they did surgical iridectomies at this time, or they had phacoemulsification cataract surgery. And most of the eyes in the iridectomy group still needed additional pressure lowering surgery, very few in the cataract surgical arm. And that really points to an important possible treatment, which was then studied in Hong Kong to look at whether you could do early lens extraction after an acute attack. These surgeries are typically done 4 to 6 weeks after the attack, once the eye has quieted down. This study compared treating with early lens extraction or iridotomy and set the failure at an eye pressure of 21 or higher off medications. And you can see really a very dramatic difference between the two arms. The phaco group had almost no failures, just an early one or two, and then none. And the LPI group had increasing failures of pressure. So people developed high pressures over time with a hazard ratio that's really almost never heard of, 14 for the iridotomy eye failing. This really made clear to me that we should be doing early lens extraction because you are avoiding scarring and long-term pressure control issues in these patients by removing their lenses. And really, once you've had an acute attack, the likelihood of needing cataract surgery in the not too distant future is quite high. This study was replicated in Singapore. They had slightly different failure criteria. You had to have quite elevated pressures, and that's why the failure rates were a little bit lower in the iridotomy group. But that said, they found quite similar findings to those from Hong Kong with a hazard ratio of about 5. So then people started saying, what about those with chronic angle closure? We have a lot of patients who have angle closure and angle closure glaucoma. Could we take out the lens and lower their pressure and prevent glaucoma in them? And this just shows that if you had no effect, you would have a similar pressure before and after surgery. It was slightly higher after surgery in this patient. But if you had pressure lowering, you would see more of the points in this area. This is somebody who started at 20 and ended at 12. And basically anybody in this area of the curve had pressure lowering. In this study, one of the early ones shows that cataract surgery and chronic angle closure does seem on average to lower pressure a bit. This and the other studies I've discussed led us to design a pragmatic randomized clinical trial. This enrolled patients with primary angle closure and very high eye pressures or primary angle closure glaucoma, and they were randomized to cataract surgery or iridotomy. And if both eyes were eligible, they received the same intervention. And that's because the main outcome in this study was a quality of life outcome. And I'll go through that in a minute. And patients are followed for 3 years. And this is the EAGLE trial, which is really a quite impressive study led by Augusto Azuaro Blanco, who did all the work. I just helped advise the study. So for this study, you had to have angle closure glaucoma and the pressure had to be 21 or higher, or you had to have angle closure and a very high eye pressure of 30 or higher. And one thing to remember when you think about this study is all reported outcomes are on a combination of these people. So we don't really have an answer for one or for the other group. We have an answer for the combined group. And that was necessary because at the time, there was a lot of skepticism of doing early clear lens extraction. So these are clear lenses, people with good vision, just taking out the lens to treat glaucoma. There was a lot of reluctance. And so we had to get more patients in a reasonable time frame, and we included those who clearly would develop glaucoma, people with primary angle closure and very high eye pressures. But the results were all powered for this combined cohort. These patients also had at least 180 degrees of angle closure and were newly diagnosed and over the age of 50. And the reason we included over the age of 50 is we were taking out people's lenses, and so that would make them immediately presbyopic, and we didn't want to disrupt people's happiness too much by doing that. This was not meant to be a study of rare glaucomas, of nanophthalmus, or anything like that. And so we didn't include very severe glaucomas, and that was partially as a safety measure. And people like cataracts obviously couldn't be in, and the others are listed here. So I said the primary outcome was really a quality of life outcome, which is called the EQ5D, or the European Quality of Life 5 dimensions. And I'm just going to briefly explain that here. The dimensions are these 5 dimensions: mobility, self-care, activities. And you just answer that you either have no problems, some problems, or extreme problems, and you get a score. They also looked at clinical measures, eye pressure, and economic measures, the cost for treating. And this was mainly a European study, mainly a UK study, but they did have an Australian site. They had some Asian sites, none in India. About a third were Chinese. These were older individuals on average, and most of them were the angle closure glaucoma group, but there were a bunch who were primary angle closures, and they started with pretty high eye pressure to begin with. So if we look at the primary outcome, the EQ5D score, what you see here is at baseline, they were very similar, and that the laser iridotomy group worsened by a bit, and they didn't worsen at all in the surgery group. And you could imagine that taking out lenses in hyperopic individuals would improve quality of life a bit. And so overall, even though there were age-related declines, no overall decline in that group was seen. So this was actually statistically significant and showed a benefit to early lens extraction. In terms of pressure, the results are even more impressive. If you look at the lens extraction group, the mean pressure at 36 months was 16.6, lower than the mean pressure in the iridotomy group. And this is despite the fact that the iridotomy group was on far more medication. The lens extraction group, almost 2/3 of them were on no medicine. So an average of 28 or 29 down to an average of about 16.5 on no medicines in the majority of patients, which is really striking. And you can see here the overall average medication. And one other finding that's very important is that a lot of the patients in the laser group had lens extraction to lower pressure. These are pressure lowering procedures. And they had others as well. So they had 24 pressure lowering procedures, and they also had cataract surgery for other needs, for vision. And so if you look at this, this is a total of 28 patients, which is over 10% within this 3 years ended up getting cataract surgery. So you are doing lens extraction early, but you're gonna do lens extraction on many of these patients over time. So this is one thing to consider when deciding should I or shouldn't I do clear lens extraction. And if we look at complications and vision loss, there were a few more complications in the lens extraction group, which you would expect because only those who had glaucoma surgery or lens surgery for vision in the other arm were eligible to have a complication. But irreversible loss of vision was greater in the laser iridotomy arm. And that says to me, maybe this is true, maybe it isn't, but it really says that it's unlikely to go the other way, that it's unlikely to be the fact that vision loss would have been greater in the arm that had clear lens extraction. And there are differences by groups. So overall, the Chinese seem to get even more benefit. Those with glaucoma got more benefit than the angle closure group. Those who had both eyes involved and slightly worse vision got more benefit. And that's very similar for pressure-related findings as well. What about the IOP outcomes? The targets were between 15 and 20, and medications and so on were increased or decreased based on trying to achieve these targets. And so we've done a recent analysis where we looked at good responders who had a pressure of less than 21, but they might have been on medicines with no additional surgery, and great responders who had that pressure but no surgery and no medicines. And if you look at a good response, so about 90% of patients had pressure less than 21 on maybe on medicines or not in the laser arm, whereas 2/3 had that in the iridotomy arm. And in terms of the great response, as I said before, a huge proportion had a great response in the clear lens extraction, very few in the iridotomy arm, but there were some. There was almost 20% of patients who, if you just did the iridotomy, their pressure came down quite a bit. And that's an interesting finding, I think. And this just shows the likelihood of a great response, which is shown over time. The treatment was also highly cost effective, as would be expected. But we have to remember that cataract surgery is not without risk. There's risks of retinal attachments, of transient swelling that can also affect vision. And there are cases of endophthalmitis, and that would be a devastating consequence in some of these patients. So my take home from the EAGLE trial is that Initial lens extraction is associated with better clinical and patient-reported outcomes. It's cost-effective, but it has a risk of PC rupture, and you need to decide with the patient what they want to do. It may make sense at times to do the iridotomy, see if you get pressure lowering that's adequate, or you may decide to go straight to lens extraction. I also want to emphasize that the Eagle findings do not apply to other types. I once heard a clinician saying, oh, this person is an angle closure suspect. We did the iridotomy. The angle didn't open up. I think I'm going to take out the lens. And that is not at all justified by this study, and I would not recommend it. So what about those with angle closure without disease? Well, if you think about the population of China, it's probably not that much different in India, but in China, the population over the age of 50 is going to be twice the size of the US population in 2050. So it's going to be massive. These are older individuals who are going to require healthcare. And a lot of them are primary angle closure suspects. If you look at the Chennai glaucoma study, so looking at one done locally in India, there were nearly 300 subjects who were suspects, 106 who were angle closure, but not disease, right? These are people who have some PAS, they have maybe borderline elevated pressure, they don't have glaucoma. So if you add these together, you have almost 400 people, and you only have 34 who are angle closure glaucoma. So overall, if you look at the population of angle closure, right, all the angle closures out there, this is a population-based survey, less than 10% actually have a problem. So if you go around doing things to all the suspects, you're not really going to prevent that much disease unless it's a really effective strategy. So we did a natural history study after iridotomy in patients. We looked at patients who had been about 62-year-olds at the time of attack. They're mostly female and Chinese. And we looked at them about 6 years later. This was part of that registry study I discussed. And in attack eyes, almost half of them had glaucoma with a pretty substantial mean loss of vision. And there was this kind of pallor greater than cupping phenomenon in these attack eyes. 10%, as I said earlier, were blind in the attack eye from glaucoma. But if you look at fellow eyes, they mostly were fine. So eyes that had been at risk of acute attacks, eyes that had been at risk of developing chronic angle closure glaucoma, there was very little disease in that group. So it makes sense that you might want to try to avoid attacks. Maybe an iridotomy is an effective way to do so. And we then wanted to study that question through the ZAP study, which I'm going to talk about in a few minutes. I want to first talk about screening for angle closure. And I have to say that my overall take on the literature and what we found over the last decades is we probably shouldn't be spending a lot of time screening for angle closure. We should be screening for angle closure glaucoma, for glaucoma. So we know that gonioscopy is one of our main tools for assessing for angle closure, but gonioscopy is highly subjective. We often compress on the eye and open the angle by mistake. We don't fully agree with ourselves, and we may not be able to do it easily in many of our patients. We did study what's often taught in medical school, the oblique flashlight test. We did it in and you can see here the shadow that you're supposed to see, and you don't see a shadow here. We did this using a slit lamp in South China, in Guangzhou. And we looked at patients who had angle closure and open angle eyes and had very mediocre sensitivity and specificity. And I don't think this is a particularly valuable test. And this is a best case scenario. So I'm not sure that it's quite useful in the hospital. Paul Foster and colleagues looked at limbal anterior chamber depth. This is the Van Herrick test. And he modified it so that you actually had different ways of grading it at a wider range, and found that with a cutoff of less than 15%, he had a sensitivity of 85% and a specificity of 85%, which was similar to using anterior chamber depth. A recent study of this same approach at Wilmer found that sensitivities were a little lower. And so, you may be missing disease if you use this as your only approach. But specificity is still pretty good, and it does pick up a bunch of angle closure. So I think that at a minimum, at the slit lamp, one should look at the limbal anterior chamber depth. And then there's newer devices to screen. We did a very large study in Singapore, the Singapore screening study. And this was really a very nicely designed study. In Singapore, there are polyclinics, which are basically federal, government-run clinics that provide healthcare to the majority of the population. And patients come there for their care. And we randomly selected 50-plus-year-old patients and enrolled them where they got multiple tests, including an eye exam. And this just shows the IOL master, which gave anterior chamber depth. This is a scanning peripheral anterior chamber depth analyzer, which gave multiple measures of the anterior chamber. And this is the OCT that was used. And there were a lot of subjects enrolled, which was impressive, and all the tests were performed. And what's really amazing is in this random sample of individuals going to their doctors in Singapore, almost 1 in 5 had angle closure. So really a tremendously high prevalence of angle closure. And if you look at those with angle closure, they tend to be older, more often female, and more often Chinese than other races. So even in Singapore, where they have a South Indian population, angle closure is more common among the Chinese cohort than among the Indian cohort. They were more likely to be hyperopic. They had a slightly higher eye pressure, which is a known phenomenon, shorter axial length, and shallower anterior chamber depth. So in this not population-based, but pseudo-population-based study, we were able to show all of the major findings that you would expect in angle closure subjects, all the risk factors that have been defined over the years. How did these machines perform? Well, if you have a very high sensitivity, you have extremely low specificity. And when you get to the range where you like the sensitivity, you don't have very high specificity. So the IOL master was not that effective. SPAC did pretty well. You could maintain a very high sensitivity with not great specificity, but you could imagine that you could do the SPAC, and then if there's a clinician there, if you did it in a clinical setting, anybody who screened positive would be checked again, and that might reduce your need to do gonioscopy. Some such test could reduce your need to do gonioscopy on everybody. And the anterior segment OCT was not perfect either. So what do you think about these results? I mean, anterior segment OCT is actually showing you the angle. It's performed in the dark, and it should be maybe a gold standard, but it was not perfect compared to gonioscopy, which makes you wonder about our reference standard or gold standard. Is gonioscopy the best standard? And should we be relying on that? And I think that's something that always weighs in my mind. We've done prospective studies looking at those who were found to be closed on OCT. And several years later, they were closed on gonioscopy, even though they'd been open on the initial exam. So it may be that we don't have a perfect gold standard. So should we be screening at all? That's really a fundamental question that one has to ask here. And the reason we would screen is because we could do iridotomy. And I'm showing an iridotomy performed in the midline in the horizontal plane. There's several studies related to this that we could discuss, but that is where I put my iridotomies these days. So the reason not to do an iridotomy in everyone is you do have multiple potential harms of doing an iridotomy. I just told you that 20% of people in polyclinics in Singapore have angle closure. Should we be doing iridotomies in all of these individuals? We might be causing harms by doing that. And many of them, as the Chennai glaucoma study showed, never go on to develop meaningful disease. I also was worried that iridotomy might cause more cataract or harm the endothelium because, first off, you're putting laser energy in the eye. And second, you're changing the flow of aqueous humor, and that might have an impact on these. So we developed the Zhongshan Angle Closure Prevention Study, or ZAP trial, and that was in Guangzhou. And one of the really impressive accomplishments of this study, and I want to acknowledge that Heming Wang led all of this, was we were able to screen over 10,000 people for narrow angles, and we enrolled nearly 900 subjects, which is impressive. And we kept almost all of them in the study for 6 years of follow-up. At baseline, the mean age was about 60, and most were female, which is not surprising. And this just shows that, we randomized one eye to iridotomy and left the other eye untreated. So we would expect all of these to be the same, which they are. And this just shows you the baseline factors associated with angle closure. We used a composite endpoint, IOP greater than 24 on 2 separate occasions, or the development of synechia, or an acute angle closure attack. So when you see the final results of this study, it includes any of these occurring, some of which are obviously more important than others. We did not think we would see much glaucoma develop over a short-term follow-up study, so we did not look for that specifically. So we learned a bunch from this study. The immediate impact of iridotomy, about 1 in 10 had an elevation of 8 millimeters or more at 1 hour, but only a few had a pressure elevation greater than 30, and we did pre-treat with brimonidine. Spikes were the most common in the shallowest eyes, which is an interesting finding. The total energy used was associated with spikes. So if you used more laser shots, more energy, you were more likely to get a spike, as was borderline, but the case with bleeding. If you develop bleeding, you were more likely at spikes. These iridotomies were done with a YAG only, no pre-treating. And there is a study from Moorfields showing that if you pre-treat dark irides with argon, you require less total energy. So that may be a way to avoid more spikes. We found that about a quarter of angles did not open after iridotomy. That is not surprising. That happens in almost every study. And angles lost some of their openness over time. And this just shows that when you treated patients, the angle width opened, but it declined in both populations over time by various measures. So the overall main endpoints were that we had very low rates of events. If you look in the iridotomy treated eyes, we only had 19 events. This is 6 years of follow-up in nearly 900 individuals. We had 19 events. And in the control eyes, we had 36 events. And that was a statistically significant finding. But what were those events? Well, those events were mostly PAS. That's really the only event that was statistically significantly different. Acute attacks were more common in the untreated eyes, as would be expected. We knew we'd see some acute attacks, but we didn't see that many. And we were dilating people at these visits because we wanted to assess for cataract as an endpoint. And 3 of these, and this one, occurred with dilation. So just to summarize in terms of the acute attacks that occurred, 3 control eyes and 1 LPI treated eye had an acute attack after dilation, which means that in control eyes, there were 6 attacks out of 10,000 dilations, more or less. So I would say that if anybody acutely needs to be dilated, even if they have a shallow looking AC, we should dilate them. We don't have to do an iridotomy first because the risk is very, very low. And then the other important finding is if you don't dilate patients, and if they're not expected to be dilated, there were only 2 attacks that occurred outside of dilation in the untreated eyes. So if you think about that, these were 4 attacks in 10,000 eye years, or 1 attack per about 2,000 eye years. So very unlikely that an untreated eye meeting our enrollment criteria would develop an acute attack. And these are community-based patients. So they may be different from clinic-based patients who may show up to your office because they're having intermittent attacks. So again, I think it's reasonable to consider an iridotomy for these patients. Some of them do get acute attacks, but the likelihood is very low. terms of the endothelial cell changes, we looked at endothelial cell counts as well as morphology, and had about 90 cells per image. And what we found was that the endothelial cell density was slightly lower in the iridotomy eye group, but it was a very small difference. So this is the endothelial cell density change. There was no change in hexagonality between groups. It did differ over time and not associated with anything. So overall conclusions from ZAP is that LPI was protective, but mainly against interim outcomes, mostly PAS, and most cases of acute attack occurred because of dilation. And we may be doing too many iridotomies. This is Heming Wang. This is where we did the work. There's Paul Foster, Tinong, and Heming Wang. We're all together there doing this work. And so the overall angle closure conclusions I want to leave you with is always think about removing the lens after an acute attack. You're very likely to be helping that patient if you do so. And they're going to probably go on and need lens extraction sooner than later. If a person presents with monocular acute attack, do the iridotomy as soon as possible in the fellow eye. I think EAGLE should really change how you think about treating your angle closure glaucoma patients. I do a lot more lens extraction for them, and I think it's a very effective approach. And ZAP has shown that not everyone needs an iridotomy. I'll stop sharing now and open it up for any discussion that people want to have. Thank you very much.
Many thanks for that very insightful and very, very clear presentation. I have to congratulate you on the wonderful collection of UVM images. I envy that. There are a few observations, questions that I have received, but I would like Dr. Harsh and Dr. Pradeep to go ahead first.
Thank you, David. That was really wonderfully done. And our postgraduates will really love it. The only problem is that it is now that we are changing ourselves. And all our teaching was that you do a PI, you do a peripheral iridotomy for any PACS and things like that. And now, absolutely, I think Tin Ong also took a couple of lectures for us. And now we have woken up to the fact that, yes, we are doing much more than required. And our numbers are absolutely huge. If you just take the PACS, there's no way we can do all the PACS.
Right.
So, and the problem is that many people with the old teaching end up doing it. And then and especially in our eyes, there's a lot of pigment dispersion.
Yeah.
Once that pigment dispersion is there, their pressures will go up and they say, what the hell, I came with nothing. And you me into glaucoma patient. So what the hell is that? So we are now getting into the fact that, yes. So David, really, which of the PACS, there are 2 or 3 questions, I'll put them all together. So that first is how will you decide that a PACS, which has never had the other eyes same way, we are not talking of a fellow of acute or anything like that. Would you think that doing a dilatation or doing a prone dark room test or seeing the values of the anterior segment OCT or the lens fault is going to change out, and how would we decide? Number 1. Number 2, how do you deal with an acute attack? I think that you did discuss, because Ayala was very much in for the doing the paracentesis. He was gung-ho on paracentesis, and he did for all his cases, which again, I am also very skeptical. But once he had said, and you also said that 30 gauge, maybe we can do that. But I'm very, very happy with my iridoplasty, because I'm one of the few people in India who totally subscribe to that. And even some of the chronic angle closures, we have been doing the this thing, and with a PI we do, if the angle opens up further with the peripheral iridoplasty, it helps us lower the pressures further. So please, the most important answer, when would you suggest our postgraduate to go ahead and do a peripheral iridotomy in a PACS?
So I think that's a great question. Maybe if you could mute, then I think I'm getting some feedback. Somebody could mute. So I think that's a great question. For me, the key things that drive me to do an iridotomy, first off, I leave it up to the patient. It's a discussion that the patient can choose. And I tell them that the risks of the iridotomy, I agree, in an Indian population, it's probably even higher for chronic inflammation. I don't really worry about it so much in lighter irides, but in Indians, I do think they have very thick irises and it can be a real issue. But the risks are largely glare. About 1 in 30 in most studies develop some glare, and you're taking that risk for a procedure that really only prevents a very rare harmful thing. So that's what I discuss with them. If somebody's getting repeated dilation, if they have diabetes and need ongoing regular dilation, I often will recommend that they go ahead and have the iridotomy, because I think that they are having a small increased risk every time they're dilated. I don't think it's a massive risk, but I think it's reasonable. And then for me, the darkroom prone provocative test, we did publish in BJO a while back that it did not separate out people. It did not help us in our study to determine who would go on to endpoints. And in fact, we had a comparison with another group from Guangzhou who were part of a population-based study, and pressures went up more in open angle patients than in angle closure patients. So I don't think it's a particularly helpful test. The same thing with dilation. I don't think anybody's ever shown that dilating the eye and looking for what the pressure change is will predict the long-term outcome. And so I've not used that as a provocation. And I do worry that maybe I provoke them into an attack, which probably wouldn't be so great. So for me, it's really a gut feeling. I look, and if somebody's super, super shallow and I'm just really nervous, I'll do an iridotomy sometimes. It's not the best practice of medicine. It's not that evidence-based, but there are a few people where I feel that way. But in general, I don't push iridotomy, and I certainly don't think if your healthcare system is overwhelmed that you should be spending a lot of energy trying to identify angle closure patients and do iridotomies. Regarding your second issue, yeah, I agree. I think if you have easy access to the laser and you're having difficulty breaking an attack medically, that's perfectly reasonable. And I think the laser will bring the pressure down a little more slowly, a little more gradually. But I really have found if you need to, an AC tap is pretty straightforward. Just have to tunnel, because we did have somebody who did one and didn't tunnel, and there was a persistent leak for weeks. And so you don't want to create a tunnel through the cornea that's not initially beveled, like where you go in partially and then enter.
Just one more question. If you have advanced glaucomatous damage, but the patient is controlled on medications, let us say 3 or 4 medications, and there is a little bit of a cataract, would you just go ahead and do a cataract, or will you do a phacotrab? The BFI say 20%.
Yeah, I mean, I think that's a really great question. It's a very hard one to give the right answer to. I'd be anxious about just doing cataract because they could have pressure spikes, and they would have they're already on a lot of meds, and it's possible and perhaps likely that I won't fully control their pressure. That said, having a bleb has a lot of risk. I think I'd probably lean towards doing the combined procedure, but trabs in these eyes can be perilous as well because they can get misdirection and so on. So yeah, I'd have to see the patient and be an individual decision making, but I think those are just really hard cases. It's hard to know the right answer.
Yeah, because we get a lot, all 3 of us get lots of patients like that. And what is happening of late is that a lot of patients actually don't want to get a combined done, especially because the trab basically means they'll have to stay in the city for a longer time, and we'll have to look at them for a longer time. And at least I have now been doing a whole lot of only cataracts, and we are really, I'm now waking up to the fact that actually
it can work. It can work. Yeah,
exactly. Work. They are working, and the pressure still, there'll be a spike, and the spike will be controlled by acetazolamide, and most of the patients within 2 days or 3 days, they are good. And back to
I think it's a very good argument you make. And I tend, unless it's really advanced, which is what you were describing, I tend to always only do the cataract because there's no reason to do more than you need to. You can always go back and do the trab. So I agree with you in that philosophy.
Yeah, thank you, David. Prateep, please go ahead.
Thank you very much, David. It was a wonderful talk, and we learned a lot, and we got the answer for so many questions. But angle closure glaucoma is really a very enigmatic disease for us. Now we see hardly a few patients are coming with an acute angle closure, but we see lot many patients are coming to us with 360-degree synovial closure, but they never had an acute attack. And probably it is almost 90% of patients, they never had an acute attack, but still they come to us with a 360-degree synovial closure and advanced optic neuropathy. So I don't know what mechanism plays over there. Probably it's a creeping angle closure glaucoma or what. I hope that you must have studied that also, and you must have noticed also. Second is that, my question, have you ever studied that the steeper cornea patients, they have a more risk of development of the acute angle closure as compared to the patients who have the steeper cornea? The flatter cornea patients, they develop more acute angle closure.
Yeah, we had very low rates of acute attacks, so looking at corneal curvature and so on would not have been possible in our study. It hasn't really come up clearly as a separate risk factor from all the other risk factors. And one of the problems is a lot of eye findings are highly correlated. So when you look at corneal curvature, it may be associated with AC depth, which may be associated with lens thickness. So it's hard to separate out one from the other as a predictor or cause. Although I would say that lens vault, which I brought up earlier, is a clear cause. I do find the development of PAS without symptoms always is kind of an interesting thing. I think some people may be getting slightly elevated pressures, or it may just be the iris contact. And I do think one of the reasons that India would be seeing fewer cases of acute attacks is just the much higher rate of cataract surgery that's going on in India. So a lot of those eyes are no longer in the pool. You take out their lenses, you have very high cataract surgical rates these days. And so I think you're eliminating some people who would otherwise have presented with acute attacks.
Do you always do the temporal YAG PI?
So I do it either nasally or temporally, wherever I see a crypt that is easier to laser. I find those easier, period. And I also have had I've never really had somebody complain of substantial glare to me doing it in those locations. The ones that I've seen where people came into me were always near the lid margin. And so I've just avoided that area superiorly. But there's a lot of studies that show that both are fine. And I think they both are fine. I think the key is to not be where the lid margin is, because that's where you get the prismatic effect of the tear film.
And the more dysphotopsia. So
Yeah.
Okay. That's wonderful. And the best thing what you showed is what Harsh also has mentioned is the management of the acute angle closure. It's amazing. You just do the paracentesis. I never tried. Whenever we failed to control the intraocular pressure, we did in a couple of patients, but only in the OR, and we did a proper paracentesis, not with the 30 gauge needle, but with the MVR blade, and the pressure did came down, and we managed subsequently that patient. But these patients who develop the acute angle closure is always very difficult. If you take out the clear lens, then also in our experience, the pressure doesn't come down, and they do require either additional medication or some anti-glaucoma surgery at later date.
So it'd be interesting. I've heard a bunch of ophthalmologists in India and different parts talk about how EAGLE doesn't apply to them, or the acute attack studies don't apply to them. And I think, it'd be really good to gather data. You could even, with the acute attack eyes, just look at case series of those in doctors who do the early surgery, or you could even do the full study. An EAGLE study in India would be quite valid, and I think would be a great study to do, or a post-acute attack eye study. You have huge volumes. It wouldn't be that hard to do. I tried proposing it with multiple colleagues, but they're always like, nah, not really. I don't really want to.
Well, actually speaking, when in angle closure, especially if the lens is is clear, or if there is very early nuclear sclerosis or cataract, then there is a huge resistance to to take the lens out. Whereas, as you mentioned, there is indiscriminate removal of lenses by others.
Right.
Resistance is and there's a lot of criticism too. I would imagine amongst glaucoma specialists. But high myopes, they're getting clear lens extractions
Right.
at 40. By hypermetropes, they're getting it earlier.
Right.
I
I really think it. If you think of this as a lifelong process, they're all going to get cataract surgery. So really, the risk you're adding is the risk of earlier cataract surgery. And for many of these patients, they've had an acute attack. Most of them are going to get cataracts over the next few years. Not all, but most. And if they are older and they have clearish lenses, within a decade, they're probably going to have cataracts. So I don't know. I think it's worth doing to get the pressures better for those patients. And that's the argument I make. But I do agree that people could become cowboys and they could be irresponsible. But I think in these instances, it makes sense.
Mm-hmm. Where the laser iridotomy was concerned in PACS patients, would you consider doing it when there is a family history of angle closure?
Yeah, if somebody says I'm having, I get these eye pains and my cloudy vision briefly and stuff, even if I don't see PAS, I might do it. If somebody says I have a blind relative from an acute attack, or blind from, angle closure glaucoma, I might just lean. And I do agree. I think getting a better history is valuable, and we didn't include that in these studies as a risk factor, but certainly it's something that should weigh in clinically.
Would you ever try pilocarpine just to check out whether those halos that they are getting and the pain that they're getting in the evenings may be related to this?
You could. It just seems like a lot to go through, and then it's.
Some of these fancy, I shouldn't say that, but some of the elite people who come over to us and like that, and you really, like we all discussed, there's hardly any way in which you can be 100% sure.
Yeah, exactly. So I think I would.
Yeah, one can try that out. We did there. Obviously, we don't have any this thing for that.
Right. Yeah.
It is the large voluminous lens which is responsible for the acute attack, or it's a lens vault?
Yeah, I think it's really the amount of lens into the anterior chamber, because that's really pushing the iris into a position where it can become fully blocked, where the pupil block can really happen. And that was shown in multiple studies. A lot of investigators have shown the vault is a very strong. So
predictor. Is there a cutoff beyond which one should be considering?
We don't have, people have said, and I've heard, some investigators say if somebody has greater lens vault, when you take out the lens, you get greater pressure lowering. We haven't seen that clearly in any studies. And so, Eagle could not answer that question. I think that's an area of interest. I think it could help you decide, is this somebody who would benefit the most or the least? But that was not, we didn't have enough data. When I showed you the good response, great response, we didn't have enough OCT data to look at that.
So, would we consider, say, one corneal thickness, about 500 microns, to be significant, or you just need to look into the angle and see whether it's
yeah, I make all my decisions on the angle findings. And when somebody's super shallow, obviously, then you want a really great cataract surgeon to take that lens out, because those are really nerve-wracking for the cornea.
Many general ophthalmologists ask that question because they don't do gonioscopy and they don't look into the angle. So I do get a lot of those. And there are several questions that are related. They look very similar, and I'll summarize that as: can primary angle closure patients have normal IOP? And would you be doing a PI for them?
So primary angle closure can happen with normal pressure. In fact, primary angle closure suspects in our study that defines angle closure, you can get glaucoma at lower pressures. And then that raises a question, is it the angle closure or is it just a neuropathy, that is some other phenomenon leading to the glaucoma? We do have some data, theoretical but believable, that the pressure differential may be greater in the posterior chamber than the anterior chamber. So in angle closure, you may have an actually higher pressure at the nerve head than you do at the cornea, and we may be measuring it incorrectly. People who develop glaucoma at low pressures with angle closure may be having intermittent pressure elevations. So for me, I do think that would be a reason to do an iridotomy, and we all feel that angle closure with glaucoma is an indication for iridotomy regardless of pressure. So I think it's a great question, what is the etiology of that person's glaucoma, and whether or not there is something more going on here. But I don't think, I don't think I could answer that for any one patient very easily.
So the intermittent nature of the disease should definitely be taken into consideration.
Well, the possibility that they're spiking at times or getting intermittent attacks of some sort that they're not noticing, not high enough to hurt, but high enough to damage is certainly in my mind.
Right.
Yeah.
Well, thank you very much, Professor David Friedman. We do appreciate
Sure.
the time. We had an excellent session meeting you, interacting with you. Have a good day. I'm sure it's a very busy day ahead of you.
Thank you very much.
Thank
Have a
you.
good day, guys. Great seeing you all.
Have a
Goodbye.
nice day.
Yeah. Bye. Bye.